Welcome everyone to the Venous Edge Real Cases, Real Answers section. I am Dr. Avgerinos and I will be presenting a case of chronic venous ulceration. This is a patient who came in my office September 2019 seeking help for his chronic left leg ulceration that has been going on for more than 30 years. He has leg heaviness affecting his quality of life, and his past medical history includes ulcerative colitis and the DVT 1977 due to long hospitalization. His left great saphenous vein was ablated 5 years ago, and he had a biopsy of his ulcers in 1991 that was inconclusive. At his visit, his Villalta score was 23 plus the ulcer. This is his duplex ultrasound during his visit, confirming disease of the left common femoral vein extending up to the external iliac vein. I also performed a diagnostic venogram to assess possible options for treatment. We had a long discussion and we agreed to continue with conservative management that included aggressive compression and wound care. At 6 months and 9 months, we did not see any improvement. At this point, we decided to bring the patient in the operating room for an attempt to recanalize his left common femoral and external iliac vein occlusion. Here is the patient in the interventional room suite with bilateral groins and the right side of the neck prepped for access. Under ultrasound guidance, I am trying to cannulate the left femoral vein quite low at the mid-thigh. You can see the wire here advancing up. And here is the first venogram through the diseased femoral vein, confirming significant scarring at the common femoral vein and external iliac vein, as well as multiple collaterals. With my guiding catheter, I'm attempting to find a channel to cross my wire through. I'm obtaining multiple projections and continue to try with more projections, and again, I'm unsuccessful crossing up to the external iliac vein. And following multiple unsuccessful attempts, I decided to puncture the right groin, come up and over, trying to find my way down to the left common femoral vein. At this point, I felt I had a good target to aim for, so I decided to continue with my ambigrade access. I used an 018 wire and managed to cross up to the left external iliac vein and then followed with a Triforce Cook sheath. I obtained a venogram and confirmed the bad disease of the left external iliac vein, as well as some disease at the left common iliac vein. And now, having crossed, things are relatively simple. I continue with aggressive balloon dilatation. I use an 8 mm balloon at the femoral and common femoral vein level, and continue with a 10 mm balloon at the common femoral and external iliac veins. Given that this patient's leg outflow was mainly through the left deep femoral vein, I got concerned that I might jail it. So I brought my wire up and over down to the left profunda femoral vein, and I performed balloon venoplasty with a 10 mm balloon to make sure that I would retain its orifice open. And this is the intravascular ultrasound confirming some disease at the mid left common iliac vein and severe disease at the left external and common femoral vein, significant scarring throughout. And now I continue with stenting, extending from the femoral bifurcation, that's a 12 mm VG, then a 14 mm at the external iliac, and eventually a 16 mm VG at the left common iliac vein, extending at its orifice. And after aggressive post-dilatation with an up to 16 mm balloon, this is the final result with good flow through all stents and loss of the collaterals. There's still some disease at the distal common femoral vein. However, I did not want to extend down to the femoral or profunda femoral vein. The intravascular ultrasound was unremarkable. The patient was discharged a few hours later on low molecular weight heparin for 4 weeks and subsequently transitioned to a DOAC. And here we are 8 months later. Notice the stents are widely open at all levels. Notice, however, there is significant reflux at the level of the common femoral vein, 2.83 seconds. The ulcer has been slowly granulating, but it hasn't healed yet, and the existing reflux will have to be addressed in subsequent sessions. The Villalta score, however, dropped from 23 down to 16, and the patient feels much better. This is Makis Avgerinos for the Venous Edge Real Cases, Real Answers. Thank you for attending.